As of June 24 this year, there have been more than 3.5 million confirmed cases and more than 60,000 deaths due to COVID-19. These values are 3 times and 6 times more than the confirmed cases and deaths just a year ago, and it only shows how life-threatening communicable diseases can be. Another recent report that concerns public health is the re-emergence of the polio virus that was first detected sometime in 2020, thus confirming a polio outbreak in the country after almost 20 years of being declared polio-free in the year 2000. Now I'd like to ask you a question. What if we acted faster? What if we acted proactively? How would things have changed? The onslaught of the pandemic has raised the bar for disease surveillance and response. It is for this reason that we chose the field of epidemiology, specifically on disease surveillance, to help detect and monitor public health threats and provide evidence-based disease and health program surveillance data to promptly decide on appropriate health programs for the welfare of the community, aiming to contribute to SDG 3, good health and well-being. So how did we do that? Data analytics. Our study used concepts in data analytics and visualization that support processes, generation of reports, and decision-making of our client organization, allowing early detection of disease clustering, recognizing trends and patterns in disease cases, and understanding risk factors that ultimately help in deciding for appropriate, prompt, and effective public health action. Hi everyone, I'm Patricia Estella, and on behalf of my co-researchers Shannon, Gail, Oha, Matthew, Neal, T. Lim, Andre, Emmanuel, S. Garcia, under the guidance of Ms. Marivic S. Tangkeko, I will be presenting our study entitled An Integrated Disease Surveillance and Response System for the Metro Manila Center for Health Development. Our client, the Metro Manila Center for Health Development, or MMCHD, is the regional arm of the Department of Health for the National Capital Region. It houses the Regional Epidemiology Surveillance Unit of NCR, or RESU, the leading unit for public health surveillance and response in the whole region. Their mandate is to handle the enforcement of health regulatory policies and directly communicate with local government units and private sectors in the development of local health systems and extension of technical and other kinds of assistance. According to the World Health Organization, public health surveillance systems are only useful if they provide data for appropriate public health response and control. We studied MMCHD's processes in order to find problems or difficulties that can be solved by a computer-based information system. We found that there is decentralized surveillance data and an incapacity to promptly generate reports in the MMCHD due to delayed, incomplete, and unprocessed data. The essence of disease surveillance is lost because these issues cause an inability to support quick decision-making in organizing timely health intervention programs. The implementation of these programs requires sufficient and interpreted data about the cases in the region. If data quality is flawed and if there are no appropriate evaluations present, MMCHD will not be able to organize effective health programs in response to public health threats. We were driven by the onslaught of COVID-19, which could have been possibly prevented if there was a system that provided comprehensive data and information about the disease when it was still at the early stage. Because of such critical responsibility, technology is much needed for MMCHD to connect 17 local government units and hundreds of disease reporting units, transform their operations digitally, and manage the life cycle of disease surveillance data. With these, their processes can be streamlined and would need little human intervention. This leads to the system immediately coming up with figures that help in producing fast and sound decisions for their plan of action. Moreover, this study also promotes the importance of evaluating disease surveillance and their responses, such as whether they are targeting the correct demographic and areas according to collected data. This way, the organization can have a quantifiable basis to know the effectiveness of their actions, ultimately contributing to the well-being of the whole region. The research and system are geared toward further enhancing and improving the existing processes of MMCHD. This means the system only covers their current processes, which includes the disease surveillance management processes of reporting, analysis and interpretation, dissemination of feedback, response and control, and monitor and evaluate. The use of the system is only limited to those from MMCHD, Regional Epidemiology and Surveillance Unit, Disease Reporting Units or DRUs, and Local Government Units or LGUs from Metro Manila, with the collected data being relevant information, not limited to their basic information such as age, gender, address, but also includes their lifestyle information, relevant past medical history, and all information required by existing case investigation and report forms released by DOH to be used for analysis. The study started with requirements analysis, wherein research on the field and the organization was done, along with interviews with various resource persons from MMCHD, which helped us understand system specifications and other details of the scope of the project. Afterwards, cause and effect analysis using Ishikawa diagram was done, pointing out the key problems of MMCHD, which were mentioned earlier. Literature on related systems was gathered to know effective implementations of systems that dealt with disease surveillance and data integration. These served as the basis to create and build upon ideas for the implementation of the system and its modules and features. For the development of the system, the Scrum method was used as the project management technique. This method followed iterations of bi-weekly intervals or sprints of development, regular stand-up meetings, testings, and feedback sessions. The system was created using Node.js and Nuxt.js as the backend and front-end frameworks respectively, with MySQL as the database management system and using Amazon Web Services as the cloud hosting platform. Microsoft Power BI was also used for the dashboard and analytics charts. IDSRS was developed for MMCHD as a decision support information system. It specifically supports MMCHD in monitoring and analyzing immediately notifiable disease cases, weekly notifiable disease cases, and health events for prompt public health action. This is achieved through 5 modules: patient and case management, analytics and visualization, feedback and report management, programs documentation, and program and surveillance evaluation. The first module, Patient and Case Management, handles data entry where patient, disease case, and health event details are recorded by DRUs into the system. In filling up the form, previous patient records can be accessed by authorized users, easing data encoding. To introduce change in their paper-based operations, this module features electronic forms available on web and mobile devices with appropriate data validations to eliminate the issue of incomplete data, as well as enough tooltips to guide users in filling out the forms, even without medical background. Furthermore, the module also supports forwarding cases to laboratories for DRUs that are not capable of testing specimens to confirm disease cases. The chosen laboratory can update the disease case information within the system itself. The most important problem that this module addresses is the timeliness of reports. This module has an automatic submit functionality wherein case report forms recorded by DRUs are automatically submitted to MMCHD at a specified time that only MMCHD can set. In case the DRU has not yet recorded any case for a particular week and the function is triggered, their submission is tagged as a 0 report, which is important when evaluating the DRU. To still account for late cases, DRUs are still allowed to add them to a particular CRF, but similar to 0 reports, they are tagged as late cases and are also crucial when it comes to evaluation. IDSRS does not only support an indicator-based surveillance approach where disease cases being monitored are only those verified and tested by hospitals or laboratories. The system also supports an event-based surveillance approach through the event-based surveillance and response feature, where details of health events that impose risks to public health, regardless of veracity, are being collected for MMCHD to verify and act upon. This widens MMCHD's reach in catching all events that may negatively impact public health in the region. The second module allows MMCHD to immediately analyze the collected data from Module 1. The system is able to generate both descriptive and diagnostic analytics using Microsoft Power BI. Previously, MMCHD has to download, process and visualize data outside of the existing system. In IDSRS, the following analyses that you see on screen are generated automatically using the data collected through the system, and they help MMCHD answer questions such as, who are getting infected by and dying from the disease, specifically by age, gender, marital status, occupation, health risks, and vaccination status if applicable. Which areas are having clustering of disease cases? When are disease cases prevalent throughout the year? Is there a trend in the disease cases over the years? And are vaccines or treatments given at the right time, place, and to the right demographic? The visualizations have different types of graphs and charts. It also features a map of Metro Manila with color indicators according to the number of cases in a specific city. The dashboards can further be filtered by month, year, disease, city, and users can also highlight specific values, and the whole dashboard will update accordingly. Overall, this module serves as the focal point of the system where decisions are influenced, such as which city needs more resources in which month. After viewing the dashboards and formulating insights from them, authorized users have the ability to create the feedback reports. They can choose weekly, monthly, yearly, ad hoc, and outbreak reports with their choice of analysis charts to include. Feedback reports undergo approval, which is assisted by the system through automatic emails and a digital approval system. Once approved, feedback reports are made available to all users across the system through the feedback bulletin feature, which notifies affected and nearby cities on the current situation and what actions to take. In Module 4, public health programs at their planning and implementation stages have their data inputted into the system through the recording of program targets, progress of vaccination or treatment rollouts, and program accomplishments. The system integrates the data recorded here with the disease case data recorded in Module 1 to provide more insights to MMCHD, such as whether these programs directly affect the number of disease cases in a particular city at a given point in time. Data gathered here acts as evaluation and performance monitoring so that programs implemented of this nature will be improved upon further. The last module addresses the problem that MMCHD is unable to maximize the data that they collect for the evaluation of the DRUs, especially when it comes to timeliness and completeness of reports. This type of evaluation can further open opportunities for the system to improve. The timeliness and completeness results may also help detect areas with limited manpower based on their evaluation, thus proactively allocating resources to those in need. We conducted usability and user acceptance testing with 4 representatives of MMCHD to gauge whether the system that we developed truly addresses their pain points when it comes to disease surveillance and response. The process involved us demonstrating the whole system to the representatives and them personally navigating through the different pages of the system. Afterwards, they were asked to answer forms with accept and reject questions as well as Likert scale questions. The results give the system an overall acceptance rate of 93.59%, with 4 out of the 5 modules receiving acceptance rates of at least 90%, with Module 2 reaching 100%. Module 4 received a 75% acceptance rate due to program accomplishments being outside the scope of the RESU. According to the representatives, the implementation of Module 4 was accurate, but it would be best to scale the system down by removing the program accomplishments collection in Module 4. With an overall acceptance rate of 93.59%, it can be concluded that IDSRS will help MMCHD, DRUs, and LGUs in analyzing diseases spread and proactively executing health programs to avoid transmissions. Through expanded data collection procedures offered by the system, incomplete and late reports will be minimized. Thus, data used are maximized to create meaningful insights for decision makers. For further research, it is promising to look into the possibility of completely integrating laboratory operations around Metro Manila to the system of MMCHD. This shall provide them with a wider snapshot of ongoing cases that are under testing or verification, thus further eliminating redundancy and delays in collecting data, analyzing, and interpreting the current situation of a particular disease. Given the volume of data collected within the system, other researchers may also look into injecting predictive analytics into the system for certain diseases, such as vector-borne and airborne diseases, which make use of environmental data. Once again, this is Julia, and thank you so much for your interest in our study.